Hi, this is chapter 36 on fluorides. The use of fluorides provides the most effective method for dental caries prevention or cavity control that is known today. Fluoride is necessary for optimal oral health in all ages, and it's made available to the tooth surface by two general means, systemically as well as topically. Now, systemically is by way of the circulation to the developing teeth, and that's during the pre-eruptive exposure. Then topically, it's directly to the exposed tooth surface of the teeth after they erupt into the oral cavity, and that's the post-eruptive exposure. So maximum caries inhibiting effect occurs when there is systemic exposure both before tooth eruption and frequent topical fluoride exposure throughout life. So make sure that you're reviewing the words, the keywords in box 36-1. And we've got our learning objectives, which you can review, but we will be reviewing all of them before the end of the chapter. Let's talk a little bit about fluoride uptake and fluoride metabolism. Now, the fluoride intake, there are certain sources of fluoride. Water that contains fluoride naturally or has been fluoridated with fluoride added to it. You can have prescribed dietary supplements as well as foods, because there's some natural fluoride found in foods. Foods and beverages that have been prepared at home or processed commercially using water containing fluoride. And then there's varying small amounts that are ingested when we use dentifrices, mouthwash, supplements, and other fluoride products by the individual. So those are some of the sources. And then we can also have fluoride intake through the bloodstream. Now, plasma carries the fluoride for its distribution and elimination throughout the body. The maximum blood levels are reached within 30 minutes of intake. Normal plasma levels are low and rise and fall according to intake. So the distribution and retention, fluoride is distributed by the plasma to all tissues and organs, and there's a strong affinity for mineralized tissues. Approximately 99% of the fluoride in the body is located in the mineralized tissue. Concentrations of fluoride are highest at the surfaces next to the tissue fluids supplying the fluoride. So you've got your fluoride ion that's stored as an integral part of the crystal lattice of teeth and bones. The amount stored varies with the intake, the time of exposure, the age, and the stage of development of the individual. The teeth store as small amounts with the largest levels right on the tooth surface. Fluoride that accumulates in bone can be mobilized slowly from the skeleton due to the constant resorption and remodeling of bone. But once the tooth enamel is fully matured, the fluoride deposited during development can be altered by cavitated dental caries or cavities, erosion, or mechanical abrasion. Now, for excretion, most of the fluoride is excreted through the kidneys and the urine, with small amounts being excreted in the sweat glands as well as the feces. There is limited transfer from plasma to breast milk for the excretion by that route. Fluoride is a nutrient essential to the formation of sound teeth and bones, as are calcium, phosphorus, and other elements obtained from food and water. A comprehensive review of the histology of tooth development and mineralization is recommended to supplement this information. And you are receiving that in your histology course. So let's talk a little bit about the pre-eruptive fluoride and that sort of thing. Now, for pre-eruptive, the mineralization stage, fluoride is deposited during the formation of the enamel, starting at the dentino-enamel junction after the enamel matrix has been laid down by the ameloblasts. And in figure 36.1, it shows the distribution of fluoride in all the parts of the teeth during mineralization. But the hydroxyapatite crystalline structure becomes fluorapatite which is less soluble apatite crystal, so it's harder. The pre-eruptive fluoride may contribute to shallower occlusal grooves and also, because of that, reduce the risk of fissure caries. Now, in Chapter 50, Table 50-4 lists the weeks in utero when the hard tissue formation begins for primary teeth, and you have a little bit of that also in your oral anatomy. The first permanent molars begin to mineralize at birth, and on Table 16.1, you can see that in Chapter 16. Now, dental fluorosis is a form of excess fluoride, and dental fluorosis is a hypomineralization that results from systemic ingestion of an excess amount of fluoride during tooth development. Dental fluorosis, again, is hypomineralization. You might think because you have more fluoride that it's going to be a harder structure, but it's not. During mineralization, the enamel is highly receptive to the free fluoride ions. And the normal activity of the amealioblasts may be inhibited, and the defective enamel matrix can form as a result in the discontinuity of the crystal growth. Dental fluorosis can also appear clinically in varying degrees, from white flecks or striations to cosmetically objectionable stained and pitted teeth. So the pre-eruptive maturation stage, after mineralization is completed before eruption, fluoride deposition continues in the surface of the enamel. And figure 36-1b shows the fluoride around the crown during maturation. But fluoride is taken up from the nutrient tissue fluids surrounding the tooth crown. Now, post-eruptive, after eruption and throughout the lifespan of the teeth, the concentration of fluoride on the outermost surface of the enamel is dependent on a few things. One is the daily topical sources of fluoride to prevent demineralization and encourage remineralization for prevention of dental caries, as well as sources for daily topical fluoride that include fluoridated drinking water, dentifrices, mouthwashes, and other fluoride preparations used by the patient. And fluoride on the outermost surface is available to inhibit demineralization and enhance remineralization as needed on a daily basis. Now, figure 36-2 depicts the areas of the tooth that acquire fluoride after eruption. And the continuous daily presence of fluoride provided for the tooth surface can inhibit the initiation as well as progression of dental caries. Uptake is most rapid on the enamel surface during the first years after eruption, but repeated daily intake of drinking water with fluoride provides the topical source as it washes over the teeth throughout the lifespan of the tooth. Fluoride concentration is greatest on the surface next to the source of the fluoride, as we've mentioned before. For the enamel of the erupted tooth, that is the outer surface of the exposed tooth next to the oral cavity. For the dentin, the highest concentration is at the pulpal surface. Periodontal attachment loss or gingival recession can often cause the root surface and cementum to become exposed to the oral cavity, and external fluoride sources then can start mineralization of those structures. So the fluoride in the enamel, we have our uptake of fluoride that depends on the level of fluoride in the oral cavity, as well as the length of time of exposure. Now, hypomineralized enamel absorbs fluoride in greater quantities than sound enamel, and it incorporates into the hydroxyapatite crystalline structure to become fluorapatite. Demineralized enamel that has been remineralized in the presence of fluoride will actually have a greater concentration of fluoride than sound enamel. Now, fluoride in the enamel surface. Fluoride, as we said, is a natural constituent of enamel. The intact outer surface has the highest concentration that falls sharply towards the interior of the tooth. Fluoride level in the dentin is maybe greater in the dentin than in enamel. The higher concentration is at the pulpal or inner surface where the exchange takes place. Newly formed dentin absorbs fluoride very readily as well. Now, fluoride in the cementum, you've got a level of fluoride that is the highest and increases with exposure on the outer surface. With recession of the clinical attachment level, the root surface is exposed to the fluids of the oral cavity, and then they can acquire fluoride that way. Fluoride is then available to the cementum from the saliva and all the other sources that we've talked about in a previous slide, the drinking water, toothpaste, and mouth rinses. So your mouth is undergoing a constant demineralization, remineralization process. And figure 36.3 illustrates the comparative levels of fluoride that can be found in the tooth surface and at sublevel lesions in early caries. Now, there's fluoride in the biofilm as well as saliva, and those are reservoirs for fluoride. Saliva carries minerals available for remineralization when needed. The fluoride acids inhibit demineralization when it's present at the crystal surface during an acid exchange or acid challenge. The fluoride also enhances remineralization by adsorbing to the crystal surface and attracting calcium and phosphate ions. So there's high concentrations of fluoride that can interact with the growth and metabolism of bacteria. And dental biofilm may contain anywhere from 5 to 50 parts per million of fluoride, and the content varies greatly and is constantly changing. So fluoride may be acquired directly from fluoridated water, dentifrice, and other topical sources and brought by the saliva or by an exchange of fluoride in the biofilm to the demineralizing tooth surface underneath the biofilm. So what's the summary of the fluoride action? Having fluoride available topically to the tooth postoperatively is the key to its effectiveness. You need frequent exposure to fluoride, such as the form in fluoridated water, toothpaste, and mouth rinses that's recommended. And there are 3 basic topical effects of fluoride to prevent dental caries. One is to inhibit demineralization. Another one is to enhance remineralization of incipient lesions. And the third is to inhibit bacterial activity by inhibiting enolase, which is an enzyme needed by bacteria to metabolize carbohydrates. Fluoridation is the adjustment of the natural fluoride ion content of a domestic municipal water supply to the optimum physiologic concentration that will maximize caries prevention and limit dental fluorosis in the enamel. So fluoridation has been established as the most efficient, effective, reliable, and inexpensive means for improving and maintaining oral health for all who use it. That is usually a public health question that you'll see on the boards as far as what is the most inexpensive, effective, reliable means for caries inhibition, and it's fluoridated water. Fluoridation was named by the USDCP as one of the 10 most significant public health measures of the 20th century. The estimated annual cost per person per year is low, with lower cost per person for communities for more than 20,000 people. Now in 2010, 66.2% of the total US population received fluoridated water, whereas 73.9% of the population served by the public or municipal waters received fluoridated water. And these percentages vary greatly from state to state. Now we need to look at the historical aspects, a little bit of fluoride. The mottled and dental caries. Now, Dr. Frederick S. McKay in the early 20th century began extensive studies to find what caused the brown stain on some people's teeth, which later was called mottled enamel, as it's now called, or dental fluorosis. He observed that people in Colorado Springs, Colorado, with mottled enamel had significantly less dental caries. The teeth looked horrible, but they didn't have cavities. He associated the condition with drinking water, but tests were inconclusive. Then we have H.V. Churchill in 1931, who was a chemist who pinpointed fluorine as the specific element related to the tooth changes that Dr. McKay had been observing clinically. Then we have Dr. H. Trendley Dean, and he did epidemiological studies in the 1930s, sponsored by the U.S. Public Health Service, and directed by Dr. Dean, led to the conclusion that the level of fluoride in the water for dental caries can prevent tooth decay if it's kept at about 1 part per million in moderate climates. Now, clinically objectionable dental fluorosis is associated with levels well over 2 parts per million, so that's twice the amount. And from this knowledge and the fact that many healthy people have lived long lives in communities where fluoride content in the water was much greater than 1 part per million, the concept of adding fluoride to the water was developed. It was still necessary to show that the benefits from controlled fluoridation could parallel those of natural fluoride, though. So water fluoridation, 1945, the first communities were fluoridated. Research in the communities began before fluoridation was started to obtain baseline information. Then we had some control cities. Aurora, Illinois, where the natural fluoride level is optimum. That was the 1.2 parts per million, was used to compare the benefits of natural fluoride in the water supply with those of fluoridation, as well as with the fluoride-free city of Rockford, Illinois. So original cities with fluoridation and their control cities were in the research. And if you look on box 36.2, you can see some of the outcomes. The research conducted in those cities, as well as throughout the world, has documented the influence of fluoride in oral health. So we need to adjust the water supply of fluoride. And since 1962, the United States Public Health Service recommended the optimal fluoride concentration of 0.7 parts per million in warmer climates and 1.2 parts per million for colder climates to prevent dental caries. And the range in fluoride concentration was based on the assumption that people in warmer climates drink more water and therefore receive more fluoride. In 2011, the United States Department of Health and Human Resources updated the recommendation for optimal concentration of fluoride in the water to 0.7 parts per million for all communities. So the decision is based on the fact that Americans have access to many sources of fluoride today than they did when it originally started. And the change still provides an effective level of fluoride to reduce the incidence of dental caries while minimizing the rate of fluorosis. Now, all fluoride chemicals must conform to the appropriate American Water Works Association standards to ensure that the drinking water will be safe. So compounds from the fluoride ion are derived naturally occurring that are mined in various parts of the world. Examples of common sources of fluoride are fluorspar, cryolite, and apatite. Criteria for acceptance of a fluoride compound for fluoridation include the solubility to permit regular use in the water plant. It needs to be inexpensive. It needs to be readily available to prevent interruptions in maintaining the proper fluoride level. And then the compounds used itself, dry compounds like sodium fluoride and sodium silicofluoride. Liquid solutions are the hydrofluorosilicic acid, and those terms are sometimes found in your public health section of the boards. For the dry compounds, I'll state it again, sodium fluoride and sodium silicofluoride, and the liquid solution, hydrofluorosilicic acid. So this is the figure that we were talking about a couple slides ago about the mineralization stage, the maturization stage of the enamel, as well as the erupted tooth. And it shows you via color the different concentrations of fluoride. So now let's take a look at the effects and benefits of fluoridation. Fluoridated water is a systemic source of fluoride for developing teeth, and a topical source of fluoride on the surfaces of erupted teeth throughout the life of the tooth. The teeth exposed to an optimum or slightly higher level of fluoride appear white, shining, opaque, and without blemishes. When the level is slightly more than optimum, teeth may exhibit a mild enamel fluorosis, such as white areas in bands or flecks. And without close scrutiny, such spots kind of blend into the overall appearance. The majority of fluorosis today is very mild and is not considered an aesthetic problem, especially when the teeth are wet in the mouth. Everything sort of blends together. But the maximum benefit is seen with continuous use of fluoridated water from birth. Estimates have shown that the reduction in caries due to water fluoridation alone, now factoring out other sources of topical fluoride, among adults of all ages is 27%. The effects are similar to communities with optimal levels of natural fluoride in the water. Many more individuals are completely caries-free when fluoride is in the water. So what's the distribution of fluoride? Now for the anterior teeth, particularly the maxillary, they receive more protection from fluoride than do the posterior teeth. So if you think about it, that's where the water is washing through. Anterior teeth are contacted by the drinking water as it passes into the mouth. So not only are the number of carious lesions reduced, but the caries rate is slowed. Caries progression is also reduced in the surface that receives fluoride from the first time after eruption. Then we've got root caries, and root caries experiences in lifelong residence to the natural fluoridated community is in direct proportion to the fluoride concentration in the water compared to the experience of residence in fluoride-free communities. The incidence of root caries is approximately 50% less in lifelong residents of fluoridated communities. And if you think about it, root surfaces aren't exposed in the oral cavity throughout the life of the tooth. So you're usually an older adult when those root surfaces are first formed, so they are lacking that daily benefit of the topical fluoride. Now, for primary teeth with fluoridation from birth, the caries incidence is reduced up to 40% in the primary teeth. And the introduction of fluoridation into a community significantly increases the proportion of caries-free children, as well as reduces the decayed, missing, and filled teeth scores when compared to areas that are non-fluoridated over a period of the same time. So for example, children aged 6 to 9 years in Newburgh, New York, had 5 times as many caries-free primary teeth present as did the children in Kingston, where the fluoride was not present in the community drinking water. Now, tooth loss due to dental caries is much greater in both primary and permanent teeth without fluoride because of an increase of dental caries, which progresses more rapidly. For adults, when a person resides in a community with fluoride in the drinking water throughout life, the benefits also continue. Now, in Colorado Springs, adults aged 20 to 44 years who had used water with natural fluoride showed 60% less caries experienced than did adults in a fluoride deficient Boulder, Colorado. In Boulder, adults also had 3 to 4 times as many permanent teeth extracted because of caries. In a survey of adults in Rockford, Illinois, the no fluoride community, there were about 7 times as many edentulous persons as there were compared to the group in Aurora, Illinois, which had the natural fluoride in it. So for periodontal infections, there's an indirect favorable effect of fluoride on periodontal health that can be shown. Improved bone density resulting from fluoride can affect the alveolar bone along with all bones, and many provide beneficial resistance against bone resorption. Dental caries lesions favor dental biofilm retention because they're rough, and with neglect of personal oral hygiene, they can also contribute to the development of periodontal infections, particularly lesions adjacent to the gingival margin and proximal surface lesions, which favor food impaction. So with the use of fluorides, particularly fluoridation, fewer teeth are lost because of dental caries at a younger age. Periodontal disease prevention and control is to be emphasized in communities with fluoride in the drinking water. Now, water with excess fluoride does not meet the requirements of the United States Public Health Service. Several hundred communities in the United States had water supplies that contained more than twice the optimal level of fluoride. So defluoridation can be accomplished by one of several chemical systems, and the efficacy of these methods has been shown. So for example, the water supply in Britain, South Dakota, had been reduced from almost 7 parts per million to 1.5 parts per million in 1948, and Bartlett, Texas, from 8 to 1.8 parts per million since 1952. So this defluoridation is important also. Examinations have shown a significant reduction in the incidence of objectionable fluorosis in children born since the defluoridation. So to bring the benefits of fluoridation to children living in rural areas without the possibility of community fluoridation, adding fluoride to the school water supply can be an alternative. Because of the intermittent use of school water, only 5 days out of the week during a 9-month school year, for example, the amount of fluoride added was increased over the usual 1 part per million. So let's say 12 years of fluoride at 5 parts per million in the school drinking water was done in Elk Lake, Pennsylvania. Children who had attended the school regularly had 39% fewer decayed, missing, and filled teeth than those that were in the controlled group. Not as good as the ones that have the fluoridated water throughout the year, but the greatest benefits were found on the proximal tooth surface. In schools in, for example, Seagrove, North Carolina, after 12 years with the fluoride level at 6.3 parts per million, the children experienced a 47.5 decrease in decayed, missing, and filled surfaces compared to those that were in the control group. So such systems have significance in the long history and efforts of fluoridation for the people in the United States. School fluoridation has been phased out in several states, and the current extent of this practice is unknown. So operations and maintenance of small fluoridation systems can be problematic. When fluoride is removed from community water, supplies that had dental caries control are no longer there. So Antigo, Wisconsin, the action of anti-fluoridationists in 1960 brought about the discontinuance of fluoridated water, which had been installed in 1949. Examinations in the years following 1960 revealed a marked drop in the number of children who were caries-free and a steep increase in caries rates. From 1960 to 1966, the number of caries-free children in the second grade decreased by 67%. So fluoridation was reinstated in 1966 by popular demand. You can find fluoride in some foods as well. Certain foods contain fluoride, but not enough to constitute a significant part of the day's need for caries prevention. Some examples of foods that contain fluoride are meat, eggs, vegetables, some cereals, fruit that has a small amount but measurable amounts, whereas tea and fish have higher amounts. Foods cooked in fluoridated water contain fluoride from the cooking water. Now, there's also salt. Fluoridated salt has been promoted in the United States, but is widely used in Germany, France, and Switzerland, where 30 to 80% of the domesticated market salt is fluoridated. Another 30 countries or more use fluoridated salt worldwide for its effectiveness as a community health program. Fluoridated salt results in reduced incidence of dental caries, but there's a significant evidence for its overall effectiveness. There's inefficient evidence of its overall effectiveness. Fluoridated salts currently are available and supply about 1/3 to 1/2 of the fluoride ingested. in the world. Fluoridated salt is recommended by the World Health Organization as an alternative to fluoridated water to target underprivileged groups. Then we've got halo or diffusion effects. Now, foods and beverages that are commercially processed, cooked, or reconstituted in optimally fluoridated cities can be distributed and consumed in non-fluoridated communities. The halo or diffusion effect can result in increased fluoride intake by the individuals living in the non-fluoridated communities and provide them with some protection against dental caries. And then we've also got our bottled water. Now, bottled water usually does not contain optimal fluoride unless it has a label indicating that it is fluoridated. So patients need to be advised to fill their drinking water bottles from a fluoridated water supply. There are water filters, and the reverse osmosis and water distillation systems remove fluoride from the water, but not water softeners. Carbon filters, like the ones that are at the end of the faucet or the Brita filters, vary in the amounts of fluoride being removed. Carbon filters with activated alumina do remove fluoride. So patients need drinking water that water filters may remove some fluoride from, and they need to be checked to see whether or not they are still getting the optimal amount of fluoride from their water filters. Now, for infant formula, there has been an increase in breastfeeding in the United States, but infant formula remains a major source of nutrient for many infants. Ready-to-feed formulas do not need to be reconstituted, but water is added to the powdered and liquid concentrate fluoride formulas. Breast milk may contain 0.02 parts per million, and all types of infant formula themselves contain a low amount of fluoride. The level of fluoride in the water supply used to reconstitute powdered or liquid formulas determines the total fluoride water. So the American Dental Association recommends continuing the use of optimally fluoridated water to reconstitute instant formula while being aware that the possible risk of mild fluorosis in the primary teeth may develop. Prescribed dietary supplements were introduced in the late 1940s and are intended to compensate the fluoride deficient drinking water. The current supplementation dosage scheduled developed by the American Dental Association of Pediatric Dentistry was revised in 1994 and includes children aged 6 months through 16 years of age. And Table 36.1 contains the daily dosage amounts based on the age of the child, as well as the amount of fluoride that is in the primary water supply. So clinical recommendations from the American Dental Association on Scientific Affairs include the use of fluoridated supplements for children who are at high risk for developing caries and those whose primary source of drinking water is deficient in fluoride. So you want to review the patient's history to be certain that the child is not receiving other fluorides, such as in preparations of vitamins and those type of things. You need to determine the fluoride level of all the sources of the drinking water and determine that it is below 0.6 part per million. And then you refer to the list of fluoridated communities that are available in the state and local health departments. You can request water analysis when the fluoride level has not been determined. For example, if they have well water, and determine the child's risk for dental caries. Is it high or moderately high, or is it low? So you need to reassess the caries risk at frequent intervals, as the status may be affected in the child's development, personal or family situation, and behavioral factors such as changes in oral hygiene practices. Sodium fluoride supplements are available as tablets, lozenges, and drops in 0.25, 0.5, and 0.1 milligram dosages. These are prescribed on an individual patient basis for daily use at home. There's also tablets and lozenges that are chewed, thoroughly swished around the mouth and forced between the teeth with the swishing. Lozenges are dissolved for 1 to 2 minutes in the mouth, and they provide both pre-eruptive and post-eruptive benefits because you swish and swallow. It's best taking these type of fluorides at night after the teeth are brushed, and avoid drinking, eating, or rinsing before going to bed to gain the maximum benefit. Then there's also fluoride drops, and that's a liquid concentrate with directions that specify the number of drops for the prescribed dose. Primarily used for children 6 months to 3 years, the patient of any age unable to use other forms that require chewing or swallowing can benefit from this. For the prescription guidelines, there should be no more than 246 milligrams of sodium fluoride, and that's 120 milligrams of the fluoride ion to be dispensed per household at one time. And I can guarantee that's going to be a board question. No more than 264 milligrams of sodium fluoride or 120 milligrams of the fluoride ion can be dispensed per household at one time. You want to avoid taking dairy products. When you are taking these fluoride supplements, you want to take them with juice or water because dairy contains calcium and the fluoride combines with calcium and then it's poorly absorbed. For storage, you want to keep the products out of reach of children. You want to keep the tablets in the original container away from heat and direct light and away from damp surfaces and places such as the bathroom or the kitchen sink areas. If you miss a dose, you want to take the dose as soon as it's remembered, but if it's close to the next dose, you just skip the dose. You don't double up. Now, prenatal use for prenatal vitamins in pregnant women with fluoride, the administration of prenatal dietary fluoride supplements is not recommended. There's some evidence has been shown that fluoride crosses the placenta during the 5th and 6th months of pregnancy and may enter the prenatal deciduous enamel. So overall, there's a weak evidence to support the use of fluoride supplements to prevent dental caries in primary teeth. Daily fluoride supplements offer caries protection benefits in permanent teeth. School-age children who chewed, swished, and swallowed 1 milligram of fluoride tablets on a daily basis had significantly lower caries experience than children who did not. And the use of fluoride supplements in children over 6 years of age shows a 24% decrease in decayed, missing, and filled tooth surfaces in the permanent teeth compared to no fluoride supplements. So you want to consider the child's age, caries risk, and all the sources of fluoride exposure before recommending the use of fluoride supplements. Now, there's also professional topical fluoride applications. And topical fluorides are an essential part of the total preventive program for patients of all ages. Fluoridated water and fluoride toothpaste are the primary sources for topical fluoride for patients of all ages and levels of caries risk. But additional topical fluoride sources may be professionally applied or self-applied by the patient, primarily for those who are at an elevated caries risk. So let's take a little look at the historical perspectives. Professionally applied fluoride has been instrumental in the reduction of dental caries in the United States and other industrial countries since about the 1940s. Now, Dr. Basil G. Bibby conducted the initial topical sodium fluoride study in Brockton, Massachusetts with school-aged children. More than 1/3 fewer new carious lesions resulted from the 0.1% aqueous solution applied 4-month intervals for 2 years. So every 4 months, the child was getting a fluoride treatment. The research led to extensive studies by Dr. John W. Knudsen and others that were sponsored by the Public Health Service. The aim was to determine the most effective concentration of sodium fluoride, the minimum time required for application, as well as procedural details. So their results provided the basis for the applications of currently used and prescribed fluorides. Professionally applied fluorides are available as gels or foams and delivered in trays, or varnish that is applied with a soft brush to the teeth. So what are some of the indications? The professional application of a high concentration of fluoride preventive agent is based on the caries risk assessment for that individual patient. And we'll be going over some of those criteria in another chapter, but the patient's determined to be a low caries risk versus a moderate or a high caries risk, then that will determine what your recommendations are. And indications for the professional fluoride applications are outlined in box 36.3. So the compounds, okay, in table 36-2 provides a summary of the available professional fluoride applications that include 2% sodium fluoride gel or foam that's delivered in trays, 1.3% of the APF or acidulated phosphate fluoride as a gel or foam delivered in trays, and the 5% sodium fluoride varnish that's brushed on the teeth. And those are the types of fluorides that will be found in the professionally applied. We also have 2% sodium fluoride that's called the neutral sodium fluoride due to its neutral pH of 7 that contains 9,050 parts per million of the fluoride ion. So clinical trials demonstrating the efficacy of the neutral sodium fluoride are based on a series of 4 or 5 applications on a weekly basis, not just once every 6 months. Quarterly or semi-annual applications are more common in clinical practice, but for the 2% sodium fluoride foam, there's limited clinical evidence that demonstrates the foam's effectiveness in caries prevention. Now for the APF, the acidulated phosphate fluoride, it's 1.23% acidulated phosphate, and that contains 12,300 parts per million fluoride ion. It's a 4-minute tray application that's recommended every 3 to 6 months per year for individuals ages 6 and older. It's widely used because of its storage stability and acceptable taste, as well as tissue compatibility. Now, the low pH is 3.5 pH enhances fluoride uptake, which is greatest during the first 4 minutes. Acidulated phosphate, though, may etch porcelain and composite restorative materials as well as sealants, so it's not indicated for patients with those type of porcelain, composites, restorations, or sealants. The hydrofluoride compound of APF can dissolve the filler particles in the composite restorations, and the macro inorganic filler particles of the composite materials demonstrate noticeable etched patterns that the APF generate, whereas many of the more recently available microfilled composites aren't as sensitive to the APF. So nobody's using the macrofilled composites anymore, but there still might be some in your patient's mouths. So the prevented fraction of dental caries ranged from 18% to 41% with the use of APF or natural sodium fluoride. The 1.23% APF foam, there's limited clinical evidence to show the effectiveness of foam in caries prevention. Then we also have the 5% sodium fluoride varnish. And fluoride varnishes were developed during the late 1960s and the early 70s to prolong the contact time of the fluoride to the tooth surface. Varnishes are safe and effective, they're fast and easy to apply, and patient acceptance is pretty good. The use of the fluoride varnish 2 to 4 times a year has been associated with a 43% decrease in decayed, missing, and filled tooth surfaces in permanent teeth and 37% in the primary teeth. So varnish has a higher concentration of fluoride than does the gel or the foam. But the overall less amount of fluoride is used per application, so it's much safer. Varnish sets quickly and remains on the teeth for a number of hours, releasing fluoride into the pits and fissures, the proximal surfaces, and cervical areas of the tooth where it's needed the most. Application is recommended at least every 3 to 4 months per year for individuals that are at an elevated risk for dental caries. Varnish is effective in reversing active pit and fissure carious enamel lesions in the primary dentition, as well as remineralizing the enamel lesion, regardless of whether the varnish is applied over and around the demineralizing lesion. The varnish is also effective in reducing demineralization or the white spot areas around the orthodontic brackets. So varnish is the fluoride application of choice for many, especially those with dental hypersensitivity. And that's what it is really approved for, is for dental hypersensitivity. Varnish is the only professional topical fluoride to be used in children under the age of 6 years of age. Varnish received approval from the United States Food and Drug Administration in 1994 for its use as a cavity liner and for treatment in hypersensitive teeth. Its use in the United States as a caries preventive agent is considered off-label, but it's become the standard of care in our practices. So let's take a look at some of the clinical procedures for the topical fluoride application. The objectives, of course, is the prevention of dental caries. We want to identify special problems, including areas adjacent to restorations, orthodontic appliances, xerostomia, and other risk factors. Examples: active or secondary caries, exposed root surfaces, orthodontic treatment, low or no fluoride exposure, or compromised salivary flow. They're also good for remineralization of demineralized areas. So the demineralized white spots on the cervical third, especially underneath the dental biofilm, can become remineralized. Fluoride can be used for desensitization. Fluoride aids in blocking the dental tubules. And varnish covers and protects the sensitive area, and fluoride then is slowly released and uptake is being done. So you want to prepare the teeth for the topical application, and the general application for trays and varnish applications. You want to instruct the patient about all the methods for caries prevention and how they work together. Most patients will receive the professional topical application following their routine maintenance appointment with the complete dental hygiene procedures of personal oral hygiene care, instructions, scaling, and stain removal. When the fluoride application is to be applied at the time other than following scaling or debridement, rubber cup polishing is not necessary anymore, because the fluoride will penetrate some biofilm and provide the same benefits with or without prior polishing. Calculus and stain removal are to be completed, but after calculus removal, you want to apply the principles of selective polishing for stain removal. You want to select an appropriate cleaning or polishing agent that won't harm the tooth surface or the restorative materials. A fluoride-containing polishing paste is not effective as a fluoride application. It is not the fluoride application itself, but preparation and procedure of a gel or foam or tray application or a varnish is necessary. So you want to help the patient understand the purposes and benefits of the fluoride, as well as the limitations. You never want to give the patient a guarantee that this will prevent cavities. The fluoride is one of the part of the total prevention programs that includes daily biofilm control and, of course, the limitation of cariogenic foods. So let's talk a little bit about the tray technique, okay, for the gel or foam. You want to schedule the appointment at the end at least 30 minutes before the patient needs to eat. The preparation of the patient for any discomfort, it's going to be a 4-minute time. You want to let them know that the trays will be in the mouth for 4 minutes and explain that they aren't to swallow, but they need to expectorate or spit immediately after the tray is removed and not swallow the gel or the foam. And you want to select a tray that has sufficient coverage of the exposed teeth as well as the root surfaces. I'm just going to flip this here so you can see the tray selection. But the design of the tray, there's maxillary and mandibular trays that can be hinged or separated. And this shows you the different types. These are unhinged, so you've got a tray for the top, tray for the bottom, and you use something called a thixotropic gel, which offers a better physical and handling characteristic used in the trays. It's a thick tray, or I'm sorry, a thick gel that's on a flexible tray. And the procedures for the gel and the foam we're going to be getting into. Versus the varnish technique. And the varnish application is you schedule the appointment, they need to refrain from hard foods and hot liquids because you don't want to chip that dried varnish off, versus with the gel or the foam, they just can't eat or drink for 30 minutes. You dispense the varnish depending on the packaging. You can get some in tubes, but most have single dose packets, and you discard any of the clear varnish because the ingredients have separated, but you're going to mix it, okay, before you apply it. The unit dose 5% sodium fluoride varnish is available in pre-measured wells. You take the end of the brush, the stick end, and you mix it really well. You don't use the brush part. And the fluoride is one part of the total prevention program. Again, biofilm, daily biofilm removal, and the limited cariogenic food. So for the tray application, all right, we talked about nothing to eat or drink for 30 minutes. And then we also have self-applied fluoride. So the professional applications are tray with the gel or the foam, or the fluoride varnish. And we also have self-applied fluorides. And self-applied can either be prescription or over-the-counter that are available in dentifrices, mouthwashes, or mouth rinses and gels. The concentrations are 1,500 parts per million or less can be sold over the counter. Some products containing less than 1,500 parts per million are available only with a prescription. They may be supplied by toothbrushing, by rinses, by trays that are custom made or disposable. So a patient needs need to be determined with the caries risk assessment, and indications for the use and the type of the fluoride application needs to be determined as well. Certain patients need multiple procedures combined with professional applications at regular maintenance appointments, and special instructions are suggested for each method. So some of the methods, okay, we'll discuss 3 of them: tray, rinsing, and toothbrushing. So for the tray, you have a custom-made or disposable tray. The tray is selected to fit the individual mouth and completely cover the teeth being treated. You want to make sure that you have adequate coverage. You instruct on how to use it by not overfilling the tray, because you don't want the patient to be swallowing. Then there's fluoride rinses, and the patient swishes for about 1 minute, a pre-measured amount of fluoride rinse, and then expectorates or just spits out. Certain patients will need to learn how to rinse properly because you really need to force the solution between the teeth. It's not a gentle swishing. You want to force that solution between the teeth. Then there are some fluoride containing dentifrices or gels that can be used on a toothbrush, that can be used after breakfast and before going to bed. Brush-on gels are used after regular brushing and provide an additional benefit to the dentifrice. And the use of interdental brushes to apply fluoride are also recommended for those that have open embrasure spaces. So you want no more than 2 milliliters of gel that's placed in the tray for children. No more than 5 milliliters of gel is placed in each tray for adults, and this amount fills each tray to about 1/3. So these are usually prescription gels used for home, and they can be custom tray or disposable tray. And it's been shown to be quite effective. You can use 1.1 sigillated phosphate or plain sodium fluoride gel. The gel can be applied in the trays, and it's been shown that dental caries incidence can be reduced up to 80%. So when you've got rampant enamel or root caries with persons of any age, and you want to prevent new additional carious lesions, they might be a good candidate for something like this. Xerostomia patients that have a salivary flow dysfunction are at an extremely higher incidence of tooth decay probability. Exposure to dental radiation, for example, that kills the salivary glands. Root surfaces that are hypersensitive. You can use gels, 1.1 sodium fluoride gel, 5,000 parts per million, or 1.1% APF, 5,000 parts per million. So you want to dispense these in small quantities. The maximum adult dose is about 16 drops per day. So that's about 4 to 8 drops in each customized tray. The neutral sodium preparation on porcelain, composites, titanium, and sealants doesn't affect those type of materials. The APF does. So you want to be careful with what's in the patient's mouth and advise them to use the appropriate type of fluoride. Now there's fluoride mouth rinses, and mouth rinsing is a practical and effective means for self-application of fluoride for those that are at a moderate to high caries risk. It's not to be used in children 6 years or younger, or for patients that can't physically spit. Rinsing can be a part of an individual care plan and can be included in a group program conducted during school. Mouth rinsing with the fluoride preparation may be an additional benefit for young children during the high-risk preteen and adolescent years, or patients with areas of demineralization, or patients with root surfaces that are exposed following recession or periodontal surgery, as well as participants in a school health group program for all grades except for the first grade because they're too young. They will be swallowing more than they will be spitting. But patients with moderate to rampant caries risk, or who live with fluoridated or defluoridated areas, can benefit from additional fluoride mouth rinses. Patients whose oral health care is complicated by biofilm retentive appliances, think about orthodontics, partial dentures, space maintainers, patients with xerostomia from any cause, and patients with hypersensitivity to the exposed root surfaces can all benefit from fluoride rinses. Now, there are some limitations. Children under the age of 6 shouldn't be using it because of their facial musculature. They won't be able to spit, as well as other patients that have problems being able to spit for whatever reason. Now, a lot of these fluoride rinses contain alcohol, and that's not recommended for certain individuals. Alcohol-based mouth rinses are not recommended for children. Alcohol content of commercial preparations is not advisable for children or adolescents, for that matter. Alcohol-containing preparations are never to be recommended for a patient in recovery or a history of alcoholism that would not necessarily be known to the clinician. So compliance is greater with a daily mouth rinse than with a weekly rinse because it gets to be part of the patient's habit. Oral rinses are categorized as low potency, high frequency rinses, or high potency, low frequency rinses. The most low potency rinses can be purchased directly over the counter, whereas most of the high potency rinses are provided by prescription. Low potency, high frequency, again, are usually over the counter. They're 0.05% sodium fluoride, or 230 parts per million, or 0.44% sodium fluoride. The over the counter, depending on the brand, is about 100 parts per million. There's, again, no more than 264 milligrams of sodium fluoride, or 100 milligrams of fluoride can be dispensed into one household at any time. So a 500 milliliter bottle of 0.05% sodium fluoride rinse contains 100 parts per million. And the bottle is required to have a child-proof cap. Rinses are not to be used by children under 6. Young children, again, can't spit out effectively. The rinse is to be fully expectorated without swallowing. So the low potency rinses are used once or twice a day, and you're only using about 2 teaspoons of it, or 10 milliliters after brushing and before retiring. The adult or pediatric maximum dose is 10 milliliters of solution. You swish vigorously between the teeth, and then you expectorate. You have to have the patient to practice rinsing at the dental chair to make sure that they're going to be able to do that. Then you've got the high potency, low frequency prescription preparations, and those are usually 0.2% or 905 parts per million. Originally recommended as a weekly rinse, but it can be used up to once a day as well. The procedure for use is the same as the high frequency, low potency. You want to be able to swish vigorously, and it's been shown to have a reduction in caries of 30 to 59%. Some of the benefits of fluoride mouth rinsing has been documented many times. Frequent rinsing with low concentrations of fluoride has been shown to have a 26 to 29% average reduction in dental caries incidence, with a greater benefit to the smooth surfaces, but some benefit also to the pits and fissures. The greatest benefit is to newly erupted teeth. That enamel is still absorbing fluoride like a sponge. The program needs to be continued throughout the teenage years to benefit the second and third permanent molars. And primary teeth present in the school-age children benefit by as much as 42.5% reduction in dental caries incidence. There's a brush-on gel that can be used as an adjunct to daily application of fluoride, and regular use has been shown to help control demineralization. This provides a protection against post-irradiation caries in conjunction with other fluoride applications. So you've got your 1.1 neutral sodium gel, which we also said could be placed in a tray, and that's a 3.5 pH, so it's very good for the tooth structure. It's available in a gel, or it can be used as part of the dentifrice as well. The rationale for the dentifrice product is to increase compliance because it's just one step, but you're brushing with it and you're not swishing with water to rinse out afterwards, and it does require a prescription. Now there's stannous fluoride, which is a 0.4% in a glycerin base, and that's 1,000 parts per million, but this 0.4% stannous fluoride has been very effective in reducing caries. It's available in a gel that's used generally separate from the toothbrushing. It can be over the counter now. A lot of toothpaste, for example, Colgate Total, has taken the triclosan out of it and has put in stannous fluoride instead. There is also Crest products that contain fluoride, the stannous fluoride. It's wonderful. It helps, it's bacteriostatic, it helps demineralization, and it helps with desensitizing root surfaces. It's used once a day or more, depending on, and the patient's to brush with it for a minute, then swish it to force the liquid between the teeth before they spit out, and they don't rinse out afterwards. So we've got the development of fluoride dentifrices. And historically, they tried different compounds, including stannous fluoride, sodium monofluorophosphate, and amine fluoride. And early research objectives was to find a compatible fluoride along with the abrasive systems and formulations containing available fluoride for the uptake by the tooth surface. And in 1960, the first fluoride dentifrice gained approval by the American Drug Association, and that was a Crest toothpaste, and that contained 0.4% stannous fluoride. Fluoride dentifrice, approved by the American Drug Association, is an integral part of the complete preventive program. And patients from all ages will benefit. Toothbrushing that covers all the teeth and all the sides of the teeth at least twice per day with a fluoridated toothpaste is the foundation for all patients' fluoride regime. Now, patients with moderate or rampant dental caries are advised to brush 3 to 4 times a day with fluoride-containing dentifrice and to choose xylitol gum after a meal when they can't brush. And they expectorate, but they don't rinse out, okay, because you want that fluoride to stay in the mouth a little bit longer. Fluoride dentifrices are available in gels or pastes. Amine fluorides have not been developed or promoted in the United States, but is available elsewhere. Current fluoride constituents, you've got your sodium fluoride of 0.24%. You have your sodium monofluorophosphate, and then you have your stannous fluoride, which is 0.4 or 45%. The requirements for acceptance of a fluoridated toothpaste by the ADA is described in Chapter 30. They usually have a seal of approval, and the seal of approval is usually for caries prevention and not for anything else. But you want to advise the patient in the selection of a fluoride toothpaste and the need that they need to use it frequently and the method of application. So you select an accepted fluoride-containing toothpaste. You place the recommended amount of dentifrice on the toothbrush. Now, for children less than 3 years of age, they're brushing twice a day, morning and night, with just a smear or the size of a grain of rice of fluoridated toothpaste spread over the toothbrush. At an earlier time, right when the teeth are erupting, again, only a tiny smear or needs to be placed on the baby toothbrush. At this time, oral hygiene of the parents and family with attention to daily biofilm removal by toothbrushing can really make a significant impact on the child's want of daily oral hygiene care. The paste is then spread over the teeth before starting to brush. For older children, say ages 3 to 6, twice daily brushing. Again, nothing more than the size of a pea. So we've gone from a grain of rice to the size of a pea, small pea. And they need to be monitored to make sure that they are spitting the toothpaste out. For adults, they're saying use a 1/2-inch fluoride dentifrice, 1/2-inch stripe, okay, twice daily. Now that's a lot of toothpaste, especially if you're using an electric or power brush, and you spread the dentifrice over the teeth with a light touch and then proceed brushing your teeth with the recommended brushing. So for manual brushing, if they need extra fluoride, you're not rinsing after fluoride, again, to keep that fluoride in the mouth. Brushing twice a day gets you twice as much fluoride than brushing once a day. Patients with moderate or high caries risks that live in non-fluoridated communities may need to be brushing several times a day, again, to get that topical fluoride. But the use of dentifrice with fluoride concentration of 1,000 parts per million and above compared to a dentifrice without fluoride can prevent dental caries by up to 23%. So all patients, regardless of the caries risk, benefit from a twice daily use of a fluoridated toothpaste and consumption of fluoridated water multiple times during the day. Patients at moderate to high caries risk benefit really from additional fluoride exposure. An additional caries reduction can be expected when another topical fluoride such as mouth rinse or a gel tray is used. So when self-administration methods are chosen, the patient's cooperation is really a big factor. Age and eruption pattern influence the method selected. Again, newly erupted teeth need frequent fluoride exposure as soon as the eruption is occurring and needs to be continued indefinitely to control demineralization. Maintenance appointments are to be scheduled for frequent professional topical applications for those at moderate or high risks for continuing instruction as well as motivation regarding the daily fluoride use for all patients. So all methods are supplements to the daily use of fluoridated toothpaste. Fluoride preparations and fluoridated water have wide margins of safety. Fluoride is beneficial in small amounts, but it really can be injurious if used without attention to correct dosage and frequency. So all dental personnel need to be familiar with the following, okay? They need to know what the recommended, approved procedures are for the products being used, the potential toxic effects of fluoride, and they need to know how to administer general emergency measures when accidental overdoses occur, and that's also found in Chapter 8. There have been deaths associated with fluoride applications being administered in the dental office. So the use of professionally and recommended fluoride preparations need to be monitored. You want to know the potential toxicity of the various products and be prepared to administer emergency procedures. As I said, the dentist prescribes no more than 120 milligrams of fluoride at one time. You need to request parental supervision of the child's brushing. The fluoride products have to have a child-proof cap. And in school programs, dispensing of the fluoride product has to be supervised by adults as well. So for toxicity, acute toxicity refers to the rapid intake of an excess of fluoride dose over a short period of time. Acute fluoride poisoning is really extremely rare, but it has happened. Chronic toxicity applies to long-term ingestion of fluoride in amounts that are exceeded by the approved therapeutic level. So you've got acute, which is a rapid intake of a high dose over a short period of time, and chronic, which is a lower dose but higher than recommended over a long period of time. Accidental ingestion of concentrated fluoride preparations can lead to a toxic reaction. Then you have something called the certainly lethal dose. And that's a lethal dose, that's the amount of the drug likely to cause death if it is intercepted or not intercepted by an antidotal therapy. So the adult certain lethal dose is 5 to 10 grams of sodium taken at one time. The fluoride equivalent is 32 to 64 milligrams of fluoride per kilogram of body weight. For the child, it's 0.5 to 1 grams, and that's variable with the size of the child. Safely tolerated dose, STD, is 1/4 of the certainly lethal dose. And you can look on box 36.5 to show the STDs and CLDs for children with weights. For children under 6, however, 500 milligrams is going to be lethal. You've got a toxic dose as well, and symptoms begin usually within 30 minutes of ingestion and can persist for about 24 hours. Fluoride in the stomach is acted on by the hydrochloric acid in the form of hydrofluoric acid, and it's an irritant to the stomach lining, and symptoms include nausea, vomiting, diarrhea, abdominal pain, increased in salivation, and thirst. Some of the systemic involvements in the blood, the calcium may be bound by the circulating fluoride, causing symptoms of hypocalcemia. You have central nervous system effects. You have cardiovascular and respiratory depression. So for emergency treatment, you want to induce vomiting, either digital vomiting with stimulation to the back of the throat or the tongue by the person or by a second person. You want to call the emergency service for transport to hospital. You also administer a fluoride binding liquid when the patient isn't vomiting, and that's going to be either milk or milk of magnesia. So if part of the post-op instructions, if the child is a little nauseated or queasy afterwards when they get home, they can have some milk or yogurt or something like that. Lime water is also something that can be used. You want to make sure that the child's breathing. Again, if it's very dangerous, you are calling the emergency services, and hospitalization is going to be resulting. So take a look at the textbook and just review some of the symptoms for toxicity. Dental fluorosis, ingestion of naturally occurring excess fluoride in the drinking water or fluoride dental products can produce visible fluorosis, but only when it's during the formative years of the enamel crowns. No systemic symptoms usually result from fluoride. An individual has protection against dental caries when they're ingesting the fluoride. So there's a scoring system that used to describe dental fluorosis that's found in chapter 23. There's mild fluorosis, which can be mild to very mild forms, and that appears as white opacities with the enamel. And there's usually no aesthetic or medical concern with that, because when the teeth are wet, they have a more uniform appearance. But it's usually speckled, and there's something called enamelplasty that can be done, where a special diamond paste is used with a diamond burr, thinking that the fluorosis is very superficial, so you can buff the outer layers of the enamel off to see if that can cosmetically uniform the color. But all white spots of the enamel are not related to fluoride intake, so you really need to be aware of what the cause of the white spots are. You want to reduce the fluoride sources. Mild fluorosis can result in inadvertent ingestion of excessive fluoride by young children. And no problem exists when care is taken with proper fluoride. Most common symptom is going to be an upset or queasy stomach. So the chapter goes into how to calculate amounts of fluoride. And there's a flow chart there. You want to multiply the percent of fluoride ion in the compound by the molecular weight conversion ratio that's found on chapter 36.6. And you obtain the ratio by dividing the molecular weight. I'm not going to ask you to memorize this. I did when I was in school, and we had to calculate these things. However, I haven't seen anything on the boards requiring you to calculate, but you do need to know what the certain lethal dose is. And like everything, you're going to be documenting. You are going to be performing a caries risk on all of your patients. You're going to be asking them about their current use of fluoride toothpaste and the exposure to fluoridated water or well water. You're going to be investigating the type, concentration, and mode of delivery of fluoride, as well as postoperatively what you're wanting them to do. You're going to be giving them instructions if it's a professional fluoride application that they're going to be doing at home. And you are going to be documenting the type, amount, as well as the instructions for use of any prescription or over-the-counter patient-applied fluoride products. So fluoride is something that the patient can benefit throughout a lifetime when they have teeth erupting and in their mouth. Small children do need to have parental supervision. You need to determine whether the patient will benefit from fluoride supplements. And the patient needs to be aware that fluoride is part of the total prevention program. You can educate the patient on water fluoridation and the need for fluoride in the water if they're drinking strictly bottled water or using the high-end water filters, and that the infants can have fluoride if you are using water to water down the concentrated fluoride. So that is everything you need to know on chapter 36 on fluoride.